better get this show on the road. And I'm going to introduce our moderator, Dr. Suzanne Williams.
Thank you. Can everybody hear me? Yeah? Yes? Okay, perfect. Awesome. So I will stand here very awkwardly because I'm not sure where I'm supposed to stand, but okay. So I'm Suzanne Williams. I'm a hematologist, a pediatric hematologist. I work at St. Kitts, and I'm presenting your two speakers who are going to be speaking today. So Dr. Sarah Patterson, who's an adult hematologist at McMaster and works in the red cell disorders clinic with a specialization in sickle cell disease, and she's director of the red cell disorders lab and the adult hemoglobinopathy clinic there with a specific interest in health equity and quality of care. And then please forgive me if I massacre your name, Marie-Pascale Pocou. Oh, yay, okay. Who's a wife and mother living with sickle cell disease, who is a graduate from York University with a master's in public policy administration and law program, and works at the Ontario Ministry of Transportation. So welcome to everyone, and we'll get Dr. Patterson to start off. Thank you.
All right, I think that actually has volume to it. So I'm Dr. Patterson. I'm going to, Sarah is my actual name. And I'm going to be talking about best practices in prescribing disease-modifying therapy while not standing immediately in front of other people. How about that? All right, I do not have any particularly relevant conflicts of interest. Nobody pays me to do fun things except my job. I do sit on an Ontario lab medicine program as well as the CanHeme Gene Therapy Action Group. And these are various ways that I try to advocate for our red cell disorders and the implementation of gene therapy. But they're not paid. What I would like to do today is review disease-modifying therapy in Canada, what the landscape is, what things are approved. I want to explore a little bit of the evidence, and I'm sorry for how dry that might be, as well as some practical prescribing tricks and how I actually do this. So disease-modifying therapy is ways that we try to affect how sickle cell disease actually impacts people's lives. There are a couple of different ways we can try to target deoxygenation by giving supplemental oxygen. Voxelotor and hydroxyurea are anti-sickling agents, so they work over here. I don't know if that's easy to see. In terms of microvascular vaso-occlusion and the cells sticking to each other, we can look at anti-adhesion drugs like crizanlizumab. And when we're looking at endothelial injury due to those sickling cells interacting with the walls of the blood vessels and causing injury, there's for antioxidants, antiplatelets, anti-inflammatory drugs like L-glutamine, as well as nitric oxide modulators, which also there is a little bit of hydroxyurea fun there. So as we learn more about sickle cell disease, we learn more about areas to target and ways that we can reduce the impact of this disease on people. I think we need to take a moment to reflect on the timeline of sickle cell. Sickle cell was sort of first noted in 1910. That was when it got the label of sickle cell. And it really wasn't until the 1990s, up here in this first red box, that we started having a treatment for sickle cell, and that was hydroxyurea in the 90s. There was a little bit of a gap sort of here. The next sort of things that we started looking at were L-glutamine, which was approved over here in 2017. We see some more exciting stuff in the last, sort of 10, 15 years, crizanlizumab and voxelotor out here in 2019. But for something that's been around for more than 100 years with a name to it, with an understanding of some of the pathophysiology, this is a remarkably empty landscape. So there's an incredible opportunity for more disease-modifying therapies and for better treatments to come through. Now, that doesn't mean that the treatments that we have are bad. It just means there's lots of new opportunities, new ways we can go. Disease-modifying therapies for sickle cell that are actually approved. We're like, yes, we use lots of things. What's actually approved in Canada? Gene therapy. That's the only actual sickle cell disease modifying therapy Health Canada approved for sickle cell disease. But we have others. So what about them? Hydroxyurea is the focus of this talk. Hydroxyurea is the disease modifying therapy that I prescribe every day. I talk about it every day. People get very sick of hearing me talk about hydroxyurea. But it is the primary treatment that we have. It's an oral medication. You can take it at home. It has a number of different ways that it works. It's cost effective, and it has been studied and in widespread use since the 1990s. It is not Health Canada approved for sickle cell disease, and that mostly has to do with the timing of where the medication was in space. It was already generic. So seeking extra approval is a lot of paperwork for not a lot of bang for your buck. So it is commonly used, but not actually Health Canada approved for this indication. So it's important that I disclose that I'm talking about hydroxyurea in a not Health Canada approved indication. Conflict of interest, it's important. So why do I use hydroxyurea every day? This is a little bit about the evidence. So there are 4 placebo-controlled trials that show that hydroxyurea makes life better. It reduces vaso-occlusive crises, hospitalizations, morbidity, and our long-term data also shows mortality, which is on the next slide. I've listed some of the studies here because being from MAC in the Center of Evidence-Based Medicine, I think it's important that we know where our evidence comes from. So the multi-center study of hydroxyurea in 1995 was sort of the first adult and children study that we looked at, but it has continued to show improvement at the population level in subsequent trials, including up to 2024. Long-term data shows that hydroxyurea, when tolerated, can help people stay alive longer and better. And for this reason, it's certainly an important medication in my toolkit, though it's not perfect for everyone. These 4 trials really looked at severe sickle cell disease. So sickle cell anemia, HBSS, HBS beta naught. This is not looking at HBSC. But that's okay because we did look at that. This just came out at ASH last year. So the PIVOT trial looked at hydroxyurea in patients with SC sickle cell disease. This is the first actual placebo-controlled trial that we have of that. And it did show that hydroxyurea was able to reduce complications, including hospitalizations in patients with SC sickle cell disease. SC is a little bit tricky because people with SC tend to have a bit of a higher baseline hemoglobin and a higher baseline hematocrit. And we know that a higher hematocrit in sickle cell disease can be associated with microvascular complications, particularly retinopathy and avascular necrosis. Hydroxyurea, in one of its ways, boosts up your fetal hemoglobin, thereby boosting your total hemoglobin, thereby boosting your hemoglobin and hematocrit. And that's why it took so long to get this evidence, because we wanted to make sure that we weren't trading off one set of disease complications for another, and that I wasn't using a medication that would increase risks of stroke. You know, that's not really something any of us would like anybody to have if we have a choice. But we did not see that sign in this trial, and we're looking forward to more evidence in this space. So hydroxyurea in SC, SS, S-beta thal, in sickle cell disease, hydroxyurea seems to help people live longer and better. Is it for everyone? I try to sell it to everyone. Not everybody likes it. Not everybody can tolerate it. But I do think it needs to be considered. And again, it's the most widely available, easy to take at home medication. Some of the disease complications that can be helped by sickle cell, areas of evidence that we have, are patients who have abnormal transcranial Dopplers, which is an ultrasound of how the blood is moving in the blood vessels of the brain. When that's abnormal, it's associated with risk of stroke. So if you have that risk factor before you have a stroke, hydroxyurea initiation can help prevent the risk of a first stroke. We know that vaso-occlusive crisis, priapism, symptomatic anemia, and renal disease, as well as proteinuria, organ damage, and pulmonary hypertension can all be benefited by hydroxyurea, at least at the population level. Stroke at the absence of transfusion therapy is up there because transfusions are the gold standard for stroke. When people have had a stroke, when they looked at the benefits of hydroxyurea compared to transfusion therapy, hydroxyurea alone was not as good at preventing a secondary stroke. And when we tried to stop transfusions, there was a higher risk of secondary stroke in those populations. So in a head-to-head apheresis exchange, hemoglobin S less than 30%, in sickle cell with stroke, transfusions was the best thing to prevent a second stroke. So hydroxyurea is great, and if you don't have transfusions, hydroxyurea is super important. And I think everybody should consider it, but it is not magic, it's not the only thing, and it's not always the right thing. So if you don't have transfusions, I like some hydroxyurea. I will talk more about transfusions later. So hydroxyurea, how do we do it? Good thing, there's lots of instructions in the literature. So generally, we start somewhere between 15 and 20 milligrams a day. And then we adjust that dose to the effect level that we're looking for. We can increase by 5 milligrams per kilogram per day. This is why your doctor wants your weight. It's not to make a judgment, it's so I can make sure the medications are at the right level. And I need to adjust the dose with enough time that that effect is able to sort of be reflected in the blood work to allow me to get to the dose that is desired. Generally speaking, I'm looking for maximal tolerated dose. Maximal tolerated dose is a dose at which the bang for your buck of hydroxyurea is the best in terms of the best boost of hemoglobin, the best boost of fetal hemoglobin, before I induce dose-limiting toxicities, which are generally cytopenias. Maximal tolerated dose is listed here. So we want to bring the neutrophils down a bit because the neutrophils are sticky. And if you have less neutrophils, you have less stickiness in that blood vessels floating around your body, and therefore the blood moves better. I want that neutrophil level at about 1.5. I do not want it below 1, because if you don't have enough infection-fighting cells and you have an increased risk of infection, that's really not helping people stay better. I don't want people's platelets, their blood clotting cells, to be below 80 because I don't want increased risk of bleeding. There is already an increased basal risk of both bleeding and thrombotic complications of sickle cell. And overall, I really want enough hemoglobin in the body that people can carry oxygen and get oxygen delivery to their important tissues like their brains and their muscles and their heart organs, etc. So I want the overall hemoglobin above 50. I want to get a little bit of an effect where I can see, but I don't want those numbers to go so low that we have dose-limiting toxicities. So when I talk about maximal tolerated dose, this is what I'm talking about. These are the numbers that I'm using. We generally use maximal tolerated dose in my clinic as opposed to a fixed dose. There hasn't been a lot of literature and a lot of solid evidence as to why you'd pick one or the other. In an area where you have access to routine lab testing, we tend to prefer maximal tolerated dose because I find that I can get to the most bang for my buck, but because it is a little bit like a pyramid, and if you go past that maximal tolerated dose, or if somebody has a change in their health, a significant weight loss, an intercurrent illness, you may go past that maximal tolerated dose and those numbers might change. If you're looking for maximal tolerated dose, you do want routine lab work and access to routine investigations. Some places in the world, there aren't as much access to such things, or the coordination of getting someone to clinic in order to target maximal tolerated dose is not as feasible, and certainly fixed dose benefits are there, though it looks like maximal tolerated dose seems to have fewer SCD complications like vaso-occlusive crisis, acute chest syndrome, less transfusions, and less hospitalizations. So there is no right or wrong answer, but maximal tolerated dose seems to have a little bit more bang for your buck when you have the resources to follow closely in that way. Hydroxyurea does not work today. Hydroxyurea works over time. It doesn't work if you don't take it. It doesn't work sitting in a bottle on the table. So we do tend to continue it through hospitalizations. We sometimes start hydroxyurea in hospitalizations. The only times when I don't is if somebody has severe reticulocytopenia, because I want to make sure they're able to make blood rather than suppressing their bone marrow more. And if someone has overwhelming illness or overwhelming sepsis, that's probably not the best time to be throwing a little more hydroxyurea at them. But once they are over that, we do generally continue hydroxyurea. I think the evidence behind hydroxyurea is great. I'm not the one taking it. And I think it's incredible that we are here today and that this is a SCAGO event and that we have the opportunity to hear from people who've had the other side of the experience of hydroxyurea, because there are barriers to this medication. Taking a medication every day of your life, whether you feel good or bad, for benefit in the long term is always hard. We see this with hypertensive medications. We see this for anything preventative. This medication was developed as a chemotherapy, and there is an association with malignancy, though we have never seen an increase in malignancy in sickle cell patients taking hydroxyurea. It is on the package insert, and it has certainly been seen when we use this because people with cancer are more likely to have other cancers. So when hydroxyurea is used as a chemotherapy, that is 100% a signal, but we have not seen a signal of increased malignancy in sickle cell patients taking hydroxyurea. It can have effects on fertility, which are often reversible, but there's a gap in the evidence there, so we can't promise that. People can get ulcers, usually around their ankles. They can get skin changes. People who are feeling well sometimes find this particular benefit risk assessment of their own individual experience to be a challenging thing. So certainly hydroxyurea has lots of good evidence at the population drug. It's an incredibly important tool in my toolkit. But at the end of the day, the person in front of me is the most important, and it's their values, their evidence, their existence that actually matters. So we got to do this hand in hand. That was a lot about hydroxyurea. What is a talk by a doctor without a table? They all have tables. So I'm not talking a lot about L-glutamine, crizanlizumab, or voxelotor. And this is because they are not, in the way that they were studied, routinely available in Canada. L-glutamine is it's a supplement. You can buy L-glutamine at the supplement store. It had a modest improvement, but the particular compound that they studied was very expensive at the doses that they used. I believe the number I heard was about $50,000 a year. It is not covered in Canada, though I have a number of people who take this in non-prescribed ways. The supplement that they studied that showed the benefit, which was, in my lovely trial, the second one here, a 25% decrease in vaso-occlusive crisis from 4 crises at 48 weeks to 3 crises at 48 weeks for a pill that costs $50,000 a year out of your own pocket is not something that I routinely prescribe because I'm not sure that the risk-benefit assessment is there. But I talk about it a lot. Crizanlizumab is one of those anti-adhesion agents, and it showed a 45% decrease in crisis rate in the first year. But when they did a phase 3 study looking at it, the evidence didn't actually show benefit compared to placebo. So when they looked at it on a big population level in a bigger trial, it didn't look like it was particularly beneficial, and it's quite hard to access because it is also not Health Canada approved. There are times when we can get access to this, but it is quite a challenge, and the benefit on a population level does not seem to be there. Voxelotor looked like it was very helpful in reducing hemolysis, but it actually underwent a voluntary recall back in 2024. So it is not available anywhere at this time due to unexpected side effects that were felt to be detrimental. We're almost there, guys. I talked a lot about prescribing disease-modifying medications. Those are the medications and the toolkits that we have. In Canada, mostly it's hydroxyurea, but it's also transfusions. So transfusions can help increase oxygen carrying capacity. They can help be used to suppress the number of sickling cells that are circulating in your vasculature, either by topping you up or by actually removing out some of that sickled hemoglobin and replacing blood transfusions back in. This can be very helpful, but it has to happen at a hospital. It often involves regular hospital trips, maybe once a month. the testing and the blood work and everything to make sure that we get the right bag of blood for the right patient often means that people are sitting for 8 or 10 hours in a hospital or have to come on multiple days for blood work and then their transfusions. So it is a timely, time-intensive therapy. It is associated with risks. Blood comes from other people, so there's always a risk of infections, albeit very low. Additionally, we have markers on our red blood cells beyond the ABO that everyone learned, which can lead to an increased risk of alloimmunization or antibodies targeted at transfused blood, which can sometimes trigger a massive hemolytic transfusion reaction where you go through to burst the transfused blood as well as your own blood, called hyperhemolysis, which is a potentially life-threatening hematologic emergency. So transfusions aren't free. They are a preciously guarded resource in Canada, but they certainly can be a really important part of therapy. And as we said, for stroke and secondary prevention of stroke, transfusions are the best. They are the Cadillac of what I have. Acute indications are acute life-threatening complications of sickle cell disease, which particularly are stroke, acute chest syndrome, particularly moderate to severe, the type that leads people to the ICU, intubation, life support, et cetera, or multi-organ dysfunction. Chronically, we also use transfusions for secondary stroke prevention. Hypertension, priapism, and leg ulcers are sometimes treated with this, as well as people who have really big issues with oxygen carrying capacity may need a little boost. People who have recurrent acute chest syndrome, recurrent severe complications of their sickle cell disease, we will often try to use chronic transfusion therapy, particularly if other therapies aren't working, like hydroxyurea. And we definitely like to send people into the marathon of surgery in the best light that we can, because we know that surgeries can trigger additional complications like vaso-occlusive pain crises and acute chest syndrome. So we like to look at people's blood and consider transfusion in the preoperative state. This is just that in a table, because I like tables. I'm not talking about therapies with curative intent, because tomorrow somebody else is. So I hope that that was a whirlwind tour. I hope it wasn't too boring or too dry about the state of disease-modifying therapy in Canada, how I prescribe hydroxyurea, and a little bit of practical guidance. Thanks.
Thanks very much, Sarah.
Okay, so my name is Marie Pascal. And I am here to talk about my experience with being on hydroxyurea. So, conflict of interest. Well, I do participate in the UHN Emergency Department sickle cell disease working group. However, I don't think my affiliation with the group has anything to do with my presentation. So, no conflicts of interest to declare there. So before I dive into my experience with hydroxyurea, I just want to talk a little bit about the history of my treatment with sickle cell disease. So first, well, as you know, I do live with sickle cell disease, particularly the SS genotype. And during, well, as a child, sickle cell disease was managed with a combination of therapies. So I used to be on folic acid, another medication that I can't really recall, and then also receiving transfusion occasionally, and that was back in the Ivory Coast. But then when we immigrated to Canada, my sickle cell was managed solely with folic acid until I transitioned over to the red blood cell disorder clinic at Toronto General Hospital. So my transition to red blood cells disorder clinic, and forgive me for the font. I thought I changed it, but unfortunately, I guess it didn't work out. But you can see that they have a timeline here. which states the beginning of my treatment with hydroxyurea going on until the period now. So at the beginning, when I transitioned over to the red blood cells disorder program at Toronto General, the hydroxyurea was introduced to me within my first appointment. And I will say that I decided to go on it, but I was not really consistent with taking the medication, to be honest. And the reason being was that first, I was apprehensive with it because it's a new medication. I felt like I didn't know much about it. But then it's something that was recommended to me by the doctors. And I thought, okay, since this is what they're saying, I have to go along with it. But I still was apprehensive with it. I also felt like I was already taking too many pills. So in addition to hydroxyurea, I was also taking a variety of vitamins. And I thought, okay, this is a bit too much for me. So I will take it some days, and some days I will not take it. It was very inconsistent. I was also trying to figure out the best time for me to take it. In the morning, I decided to take it in the morning sometimes, but I realized that it's for the mornings, with my schedule, I'm trying to rush out the door because I'm working. So it's like sometimes it's very easy for me to forget. So that also played into me not taking the medication regularly as prescribed. So this continued until the period of about 2015, 2017, and two major events happened. So first, I had a major pain episode. And then I was also diagnosed with avascular necrosis of the hip. And because of that, I decided to, reconsider my decision and start to take the medication more seriously. And the AVN was the one that played a major factor because, of course, your body is changing, your limbs are not, my limbs were not as fluid as they used to. And in conversation with my doctor, he was saying that with the hydroxyurea that because it provides a lot of blood flow to the body in general, that it may slow down the progression of the AVN. So that was one of the major reasons why I decided to continue to be more serious with the medication. So as of now, I'm still on hydroxyurea, and I will say that it has had a positive impact and long-term impact on my health. I've had a period where I didn't have any crisis for like 4 or 5 years, which is impressive because, yes. Before hydroxyurea, I used to have a crisis around for about every year or 2 years, I will have at least one major episode. Whereas when I was on it, I didn't have a major episode. Not until I got pregnant. And that is because during pregnancy, it was recommended that I do not take that medication because they don't know whether research, they don't recommend that you take hydroxyurea during pregnancy because there might be a linkage between hydroxyurea and the infant or the fetus developing some complications or some health issues later on. So I was not on it. So my experience with that is that during the pregnancy that I had, at my 35th week, I had a major pain episode, unfortunately. But after that, it resolved, like after the pregnancy, I started taking the hydroxyurea again within 1 to 2 months after I gave birth. And so in conclusion, not in conclusion, but in general, just would like to say that it has contributed positively to my life where I was able to live a full life. I was able to work, to go to school. There was a period where I was schooling and working at the same time. And there was some time where it was very stressful. And as you know, with sickle cell, when someone is stressed, when someone is stressed, that triggers an episode. But even during those stressful periods, when I was on the medication, I did not experience any pain crisis. So it enabled me to handle stressful situations without me being sick. I would like to talk about some drawbacks. Unfortunately, there are some side effects. The purpling of fingernails. How I manage that, sometimes just applying nail polish. Thinning hair, some nausea, which I experienced at the beginning. Again, I used to take it in the morning without eating. And it made me feel a little queasy. So now I take it at night, after dinner, before bed. And also some financial consideration. So if you don't have insurance coverage, it can be very expensive. There was a time when I was in between insurances. I was transitioning jobs. And I was getting the medication. The medication was renewed automatically through the pharmacy. And I went to pick up the medication, and the pharmacist told me that insurance was not going to be able to cover it because I was leaving my old job, going to a new one. But the new job was not yet providing insurance for that. And so I had to pay out of pocket, and I paid like $300. And that's when I realized how expensive this medication was. Thankfully, I was fortunate enough to have the funds to pay for that. With insurance coverage as well, it can be cost effective. And I think it depends on who you ask. For me, for example, now that I get the insurance covering it, I pay. My previous insurance with my previous insurance, I used to pay $30 out of pocket, whereas with the insurance that I have now, it's about $20. But still, depending on who you ask, people's financial situation differs. And so, depending on the person, it can be, a significant amount of someone's personal budget can be allocated to the medication, or it can be very significant for them. And with that, I would like to end my presentation. Thank you for listening.
Thank you, Marie. With that, we'll open it to the floor for questions, if anyone has questions for Dr. Patterson or Marie. Dr. Kasner.
So what's your take on supplementing with L-amino acid to increase the
I think I'm supposed to respond to this. I have not routinely recommended this, though I support things that make medications work better. Sometimes the pill burden and the sort of coordination of things is significant, especially when the dose of hydroxyurea in our adults is often between 2 and 5 pills a day. A lot of the times, additional medications, additional treatments, and I'm like, oh yes, I want your hydroxyurea, your vitamin D, folic acid if you're taking it and not getting it through your diet, that a lot of the time additional things are not, they're not things that I necessarily will tell people to do, but we are lucky enough to work at our clinic at McMaster. We have a dietitian who is helpful for working through some of those supplements and different things there. So I have not looked into it in great detail in that way. Have you, in the pediatric side?
We have not.
We have not.
Yeah. Any other questions from the floor? Oh, okay.
I had a question. Thanks for the overview on the disease-modifying therapy to get the patient perspective. Truly invaluable. The question I had was around what's coming up next with disease-modifying
don't know if I can comment on any, but there are things coming through the pipes. The PK activators are probably the next sort of category of drugs, and there's a number of different companies looking at that in various stages of clinical trials. It looks very promising so far, but I don't actually have access to any insider information. I don't. So there are certainly things coming that way. There will be likely more gene therapy type targets. I think, as we know more about the different ways that this disease affects people and the pathophysiology of disease, there's an infinite number of targets that we can try, and I think that it's really important that we keep trying and keep moving forward and keep, there's so much room for improvement in this area, and I think it's really important that we try.
Another one.
No, I just had a question about, we're moving from phenotyping to genotyping, and can you talk about, is that going to be helpful in terms of preventing transfusion reactions, or?
Yes. So their genotyping is important. Transfusion reactions and alloimmunization is a big challenge in the population of sickle cell, because most of the donors in Canada look like me, and most of people with sickle cell don't look like me in that way, and our blood also has markers that are generally categorized from different areas of the world. So people who come from different backgrounds often have different markers on their blood cells, which means that there's more risk of having a mismatch in blood transfusions when your population receiving blood is not the same population donating blood. Phenotyping, or looking for the markers on the proteins on the surface of the blood, is important, but if you have subtle changes, so partial D or weak D is one of those things that can phenotype one way, but genotype differently, or if people have a GATA mutation and we know that they don't make a particular Duffy antibody, I don't need to match for that. So genotyping is considered our gold standard, and we recommend any patient with a hemoglobinopathy, especially those going to require blood transfusions on an ongoing basis, do have RBC genotyping and extended matching to try to prevent alloimmunization so that we don't develop those complications for ongoing transfusion therapy, but also for women who wish to go forward and conceive.
Go ahead.
How close or far away are you from looking at like bone marrow transplant in our country?
Bone marrow transplants here. So matched sibling donor is here. It's not available in Hamilton, but it is done in Toronto. Calgary has a very large program for both adults and peds. Ottawa, I think, is doing transplants. Matched sibling donor, the donors. I need donuts, clearly. So matched sibling donors are the gold standard of transplant. And the reason for that is because when you take somebody else's immune system and you put it into your immune system, you want it to play nice, because if you're exchanging your sickle cell disease or your thalassemia for graft versus host disease, it's not the ideal outcome of exchanging one chronic disorder for another. With a matched sibling donor, the risk of that immune system from the donor in the host causing havoc is way less, so that's our gold standard. That's great if you have 16 siblings, and all of our patients with sickle cell have 16 siblings, right? So finding donors is challenging. So that is why it's so important that we have other options, whether that's transplants with alternative donors. Haploidentical transplants is the next thing. I'm not sure if it's totally approved in Canada for general consumption. Certainly the research looks really promising, and if it's not yet routinely available, it will likely be in the coming years. And people should have a half match, a haploidentical donor, because that includes siblings, that includes parents, that includes children. There are still risks. You still need chemotherapy, but we can often get by with a non-myeloablative transplant, so gentler chemo, because those donor cells are not as fragile as ones that have been edited with gene therapy. Gene therapy is an autologous product. It is a product from yourself. Collection is a huge challenge. because our usual collection thing that we do, if I was going to donate my bone marrow to somebody else, I would get a big whack of GCSF. GCSF helps, kick up your stem cells out of your bone marrow. But if you give GCSF to somebody with sickle cell disease, there's a risk of vaso-occlusive crisis, and there's at least one report in the literature of death associated with said vaso-occlusive crisis. So nobody wants to do that. But that means that the medication that kicks all those cells out of your bone marrow to be collected is not available, so the collection yield is way lower. And a subset of people, even if they can get to gene therapy and we've got them all set up and they qualify and it's great, they don't have a donor, we're going to save their life. If we can't get enough cells, they can't have the procedure. So it's really important that we look at all of our options and all of our different things. I think transplant, I think gene therapy, I think therapy with curative intent is incredibly important. I also think it comes with significant risk. And I think that not all people are in the best, like that risk-benefit ratio is very different for different people, and I think it's really important that we continue to have options so that everybody with sickle cell has access to disease-modifying therapy of some sort to better their lives.
In your presentation, you talked about the delay between going on hydroxyurea. Was there something you wish a physician said to you that would help you make that decision earlier, or a way in which they would have broke down the information that would have been more digestible for you?
Yeah, that's a good question. I think for me, I felt like I wasn't entirely equipped with the knowledge of the medication. Sometimes the language, the way in which it would be explained would be a bit too scientific, too technical. And at that time, I didn't have the background or the education to kind of decipher that information for myself. I also wish that it would have been a discussion more so than like advice. I know there are experts, and sometimes you're just taking that advice because the doctor is telling you that this is the best thing for you. But I think it would have been easier if there was time to actually discuss the medication in depth, so that all concerns would have been addressed. And I know doctors don't have a lot of time, right? So if there was like a pamphlet that could have been shared, or like a brochure, or even someone else who have been on the medication before coming to talk to me about it, that would have been very helpful.
My question for Pascal.
Yeah.
Post-pregnancy, restarting hydroxyurea, was it the same experience as the first time you started taking?
Experience as in, like, did I experience the same side effects, or? I think my body was already used to it, so it was just easier for me to just continue taking it. Yeah. I did have to, because pre-pregnancy I was on 3 pills per day. So when I had to start the medication again, the advice was that I just start slowly. So 1 pill, and then I think a month later, after they done the testing to see if I was okay, then gradually increase the dosage.
Any other questions? I have a question for both Sarah and Pascal. With respect to hydroxyurea and not being approved as a medication, and this is coming a bit from a pediatric lens where most of the things we use are not approved and we're always doing things off-label. But what difference do you think it makes to a patient when you present that, or do you incorporate that into the information that you're providing to the patient? And if you don't, do you think it would make a difference in the way they would perceive it in terms of wanting to take it or not? And then the same question to you, knowing that it's not approved or approved, does that make a difference to you in the way you perceive the product or use of the product, make you more likely, less likely to take it?
So, for me, knowing that it's approved, I think it will legitimize the medication a little more for me. yeah, it just gives that extra level of assurance that it's something that was studied specifically for people with sickle cell disease. Yeah, I'll just leave it at that.
I do not spend a lot of time discussing Health Canada approval of hydroxyurea in my clinic. I do talk about the evidence. I do also agree that I would love to see this Health Canada approved. I think the amount of paperwork and hurdles is significant, and that is likely why it has not been pursued at this time. But I do think it would add legitimacy, and I do think it would sort of justify the importance of existing in this space. So I think we should do it.
Thank you. Any other questions from the audience members? Any final comments from Pascal or Dr. Patterson?